speaker, Dr. Prateeba Natarajan, and professor and head of the department, anesthesiology, IGM, CRI, publications 14 international and 15 national indexed, and areas of interest, regional anesthesia, obstetric anesthesia, transthoracic echocardiography, special achievement, speaker, faculty in national and international conferences, coordinator, faculty and resource person in state conferences, workshops, organizing secretary, South Zone ISACON 2020, past treasurer, past joint secretary ISA Puducherry, member of NTF COVID and governor of Puducherry Appreciation Award for COVID services. Welcome to Dr. Prateeba Natarajan to give a lecture on anesthetic considerations in acute spinal shock. Thank you. Hand over to Prateeba Natarajan.
Good morning, one and all. At the outset, I would like to thank the organizing committee for having me here. So today I'll be talking about the anesthetic considerations in acute spinal shock. So we'll be going through the etiology, pathophysiology of spinal shock, and then we'll outline the recommended evaluation and examination for patients presenting with suspected spinal shock, and we'll summarize the appropriate management of spinal shock, and we'll see how to optimize the patient and take this patient for surgery. So spinal shock was first described by White in 1750 as loss of sensation accorded to the level of injury, along with motor paralysis and loss of reflexes, which will be an initial loss followed by a gradual recovery of the reflexes following a spinal cord injury. So we know that spinal shock is caused by the complete transection of the spinal cord. And when does this happen? Most common cause of spinal cord injury is going to be your high impact trauma, your road traffic accidents, your sports injuries. And in patients above 65 years, domestic falls, which usually happens at their place of, at their home. And then again, the cervical spondylosis also contributes to 10% of the incidence of spinal shock. And it has also been found that there is a transient spinal shock following the use of intrathecal iodinated contrast. And also spinal shock is commonly seen in patients who are in the ICU who are untreated hypotension. They can also go ischemia of the spinal cord can result in spinal shock. So these are the main pathophysiological mechanisms. That is initially there is a synaptic change in the cord segments just below the level of injury, followed by hyperpolarization of the spinal neurons, and then because of the sudden withdrawal of all these facilitatory inputs to the descending pathway, there is a disruption in the synaptic transmission and the interneuronal conduction. So there will be loss of this normal function of the spinal cord interneurons and motor neurons in the corticospinal, rubrospinal, vestibulospinal and the reticulospinal pathways. So what is of more interest to us is we need to know the level of injury that will determine the magnitude of the shock as well as how the clinical course will follow further. So the severity of transection is going to influence the severity of shock, and the spinal cord, which is closest to the injury, will be affected initially very severely, and there will be loss of reflex function. And the most distal segment, the reflexes will be depressed a little later. So a patient with a high cervical spinal cord injury they are likely to retain their distal reflexes, and those with the lower spinal cord injuries are likely to lose all their distal reflexes. And what happens is there's going to be an exaggeration of your reflexes above the level of your injury. So that's called the Schiff-Sherrington phenomenon. So we need to actually differentiate between the neurogenic shock and spinal shock. Both are actually, they are distinct entities, but they belong to the same spectrum of the process, the spinal cord injury. And how a neurogenic shock occurs is basically because of the disruption of the autonomic pathway, and there will be loss of the sympathetic tone and vasodilation. Now why we get confused is both in spinal shock and neurogenic shock we are going to get hypotension and bradycardia. That's where we are going to get confused. So you need to look for the you need to look for the signs and symptoms of autonomic pathway disruption. And you need to also know which phase your patient is going to present to us. Most of the time it's going to be phase 1 or phase 2. the initial phases only your patient is going to present. Basically there are 4 phases. So your patient is we will be seeing the patients in phase 1 or phase 2. And now coming to what exactly is important to us, we are going to see how we are going to evaluate the patient preoperatively and optimize the patient. So first is, whenever a patient comes, you take a proper detailed history, nature of accident, and you need to look, any high trauma, any high impact trauma is going to cause injuries of the other organs too, like your chest injuries, abdominal. So you take a note of all those injuries too. Any trauma patient, you always go for your rapid assessment, A, B, C, D, E. So first thing is your rapid assessment of airway, breathing, circulation and disability. And one most important thing, as a healthcare provider, you see to that you follow all the spine precautions. So the patient should be immobilized at the scene, and while you transport the patient, basically your main goal is to prevent your secondary neuronal damage. So that's the entire thing for what you are going to provide this immobilization for. So you either apply a rigid cervical collar and you put supportive blocks, you place the patient on the board, put supportive blocks, strap the patient. Even if you want to shift the patient, you go for a log roll technique. And next, if you want to intubate the patient, follow your manual, always keep your neck stabilized, or follow your manual inline stabilization and intubate the patient. So highest priority is always to ensure an unobstructed airway with adequate oxygenation and ventilation. So here the dictum is, airway management of the trauma patient is going to be the first essential step in your care of spinal cord injury. And then always remember, if there is going to be a cervical trauma at the level of C3, there is going to be an apneic respiratory arrest, while that of thoracic cord injury, most of the times the phrenic nerve and endocostal nerve is going to be involved, and that can lead to hypoventilation and hypercapnic hypoxemic respiratory insufficiency. And if you want to provide a positive pressure ventilation, always go for rapid sequence intubation with manual inline stabilization, or you stabilize with your rigid collar. And then if the setup provides, and if there is a video laryngoscopy, use it, because you will be able to visualize the glottis better. And next is your circulation and disability assessment. So as I told, all these patients will be hypotensive and they will be having bradycardia. So your first step is to start IV line and give crystalloids. And one thing you should remember, if there are no other source of injury, like there is no volume depletion or blood loss, instead of going for repetitive fluid boluses in patients with spinal cord injury, you have to start them on inotropes, basically to maintain the mean arterial pressure. And next is you check whether there is any urinary retention and place a catheter. The next step will be your neurological examination using the American Spinal Injury Association score. So in this, our patient, we have to classify in which grade our patient is going to belong to. Most of the times patients with spinal shock will belong to grade A, where there is complete loss of motor and sensory function. Okay. And as I told earlier, above the level of injury there is going to be no sensation, and there will go sensation as well as your motor function is lost, and most of the times reflexes are frequently absent in the initial stage, and your reflex will start gradually appearing at later stages, later phases of the spinal shock. And autonomic dysfunction, bowel and bladder incontinence will also be present, and they will usually present with bradycardia and hypotension. And as I told, initially your reflex, there is going to be a rostrocaudal depression of your reflex activities, and your reversal of reflexes is going to be in the opposite direction. So it is going to be caudorostral pattern. So various studies have been done, and they have found that like the rostrocaudal, caudorostral pattern of improvement of your reflexes. And first reflex to be gained will be your delayed plantar reflex, then the bulbocavernous reflex, followed by cremasteric, ankle jerk, Babinski sign, and your knee jerk. So next thing what you will be doing is you have to identify where your injury is. So your CT of the cervical spine or your spine has to be done for detecting the spinal fractures. And in patients where your CT is negative, but still your patient presents with all your clinical features of like hypotension, bradycardia, you need to go for a MRI. MRI is more sensitive than your CT finding. Now coming to how we are going to optimize this patient with spinal shock. So as I told earlier, your patient is going to have hypotension and bradycardia. This basically because yes, the sympathetic tone is lost, this will result in decrease in your vascular resistance and this will result in your hypotension. And there's going to be an unopposed parasympathetic tone which leads to your bradycardia. So first and foremost, we need to address the bradycardia and hypotension. So this is basically to maintain your spinal cord perfusion pressure. It's very crucial. In all these spinal shock, you need to maintain your spinal cord perfusion pressure basically to prevent your secondary ischemic injury. So you need to maintain your mean arterial pressure somewhere around 85 to 90 mm Hg. So you give fluids. Initially you start giving fluids, but at the same time you need to give it judiciously. You need to avoid pulmonary fluid overload and edema. And if there is a blood loss, you give blood products too. And as I told earlier, these patients don't keep pushing fluids into these patients. These patients most of the times will require an inotropic therapy. So various studies have been found. Now the confusion lies on which inotrope we are going to start off. So lots of studies have been done and they have found that noradrenaline maintains a better spinal cord perfusion pressure. And recently they have found that midodrine and desmopressin have also been used to maintain the perfusion pressures. So your bradycardia too also it has to be treated. So you give your atropine and temporary pacing also might be required, especially if your patient has higher cervical cord injuries like from C1 to C5. And usually this bradycardia resolves within 3 to 5 week duration. But during that period, you need to take all precautions to prevent the patient from going into bradycardia repeatedly. So you need to take all precautions while you are turning the patient, while you are doing suctioning. So keep your patient sedated, give 100% oxygen before suctioning and try to limit the time while you do the suction. And the other problems associated with spinal shock is like most of the patients may develop paralytic ileus, and you should be ready to take up the patient for decompression. And when this resolves, you need to build up their enteral nutrition. And the other thing is, important thing is you have to maintain their body temperature at all times. And most of the times these patients will also require thromboembolism prophylaxis. And the next important thing is prevention of the pressure ulcers with prophylactic measures. And whenever you want to move your patient, use your log roll technique. And as mentioned earlier, urinary catheter, maintain your IO charting. And all these patients should also receive your gastric ulcer prophylaxis with proton pump inhibitors for at least 4 weeks. And now coming to your spinal cord protective strategy. So it has been found that high dose methylprednisolone has an anti-inflammatory property, and it is also found to help to increase the perfusion to the injured areas of the spinal cord. And the 3 multicentric studies were done, and they have published reports in 1984, 1990 and 1970, and they have suggested a regime where you are going to give methylprednisolone bolus of 30 milligrams per kg over 15 minutes you give, and followed by after 45 minutes you go for a infusion, a 23-hour infusion. Dose is 5.4 milligram per kg per hour if you are going to start the methylprednisolone with the initial 3 hours. Now if you are going to start within 3 to 8 hours, go for a 47-hour infusion. And next, coming to autonomic dysreflexia, this is nothing but there is the sympathetic response above the injury is going to be exaggerated, and there is going to be exaggeration of the parasympathetic response below the injury. This is usually seen within the first year of injury, but it is unlikely to occur within the initial time period. So this is just for information I have put this slide, this is not within our scope. And next, coming to the timing of surgery. So any unstable surgery we need to stabilize. So, so now we have to see how we are going to take up this patient. So the perioperative care of these patients with spinal cord injury is going to be really a complex challenge for the anesthetist. So our goal is to prevent secondary damage. So these are the basic investigations which we are going to do, like for any other cases of general anesthesia. And as I told, airway evaluation becomes mandatory. This always remember to keep your difficult airway cart ready. And this is suggested anesthetic guidelines for the management of surgery for acute spinal cord injury. So preoperative preparation, review the charts, whatever charts available for how long the patient has been with us, what are the investigations done, and what was the course during the hospital period. And then pre-medication, go for a good early pre-oxygenation, and you try and limit your anxiolytic pre-medication, and then give your anticholinergics, and you also put an arterial catheter, because I told you hypotension and bradycardia is very common in these patients. Try and get an arterial catheter before you induce the patient. And then as mentioned earlier, one important thing you should always remember is, for intubating, Scolin is contraindicated after 48 hours. Less than 48 hours you can go for Scolin, and after that you can probably go for rocuronium. And another thing is, always remember it's going to be a difficult airway. Stabilize the airway. Always always remember about inline stabilization, then intubate your patient. Preferably use a video laryngoscopy. And maintenance, you always remember to maintain your mean arterial pressure between 85 to 90 millimeters of mercury. Apart from your regular monitoring, use your intraoperative neuromonitoring. The SSCPs and the MEPs can be a good guidance. Like the surgeons will will ask you to, they want to test the SSCPs and MEPs. At that time, your inhalation agents can basically come and interfere with it. It is at that time you try and maintain it with TIVA. And coming to And another important thing which you should remember is, most of the time the surgeries are going to happen in your prone position. So take all the precautions for padding the pressure points, keep the abdomen free and always secure your tube. That is more important. And one another thing you should remember is, when you're trying to come down, when you're doing your IONM, when you're trying to come down on your anesthetic agents, there is high tendency of the patient going on a lighter plane, and there can be accidental extubation also. So at that time, TIVA is extremely important to be maintained. And to reduce the bleeding, you can go in for tranexamic acid or epsilon aminocaproic acid. And however, this tranexamic acid is found to have a seizurogenic potential. So we prefer to go for a epsilon aminocaproic acid. Always aim to keep the hematocrit between 21 to 30%. And transfusion trigger will depend upon the preoperative hemoglobin, as well as it should be case by case basis, depending upon how much blood is being lost intraoperatively. And always don't overload the patient with fluids. Try and start inotropes. And patient can, if it is a very straightforward surgery, you can extubate the patient. Otherwise, keep the patient intubated, shift to postoperative ward, and mechanically ventilate the patient. So analgesia, usually multimodal analgesia needs to be followed. You can either go for IV PCA with opioids, or local anesthetic combination, and even blocks like intrapleural blocks can also be given. So so coming to the summary, most important thing is, get a good history of the patient, maintain the airway, prevent your secondary injury, and intraoperatively maintain your perfusion pressures, and always try and use strategies to minimize your intraoperative blood loss. And IONM is nowadays very mandatory. And spine protective strategies, use your methylprednisolone, and always take precautions during positioning of the patient, and extubate depending upon the procedure that has happened. Thank you.